which I think is the strangest thing of all time. But now that folks are admitted, let's get started. So what are your questions? Because you guys requested this meeting, so what's going on? Got to have a starting point.
Miss Hudson?
Yes.
So for sure, there's not like any of that like first semester information, right? Like whenever we tested, we had some first semester stuff that won't be on the.
I mean, if there are something that's first semester, I'm quite sure to be something you'll be able to figure out very quickly. It's not designed to test a lot of first semester information. But I did a brief skim over, and I may have found a couple, 2 questions, but it wasn't anything that you couldn't get, if that makes sense.
Okay, perfect. I just wanted to know, like, do I need to also like focus my time on that too? But if not, then okay, thank you.
All right. Okay. So yeah, this is supposed to be designed to my understanding, and it's been a couple days since I looked at it, and it pretty much covers your level 2 concepts. So I don't recall seeing level 1 stuff, but I will say some of it actually crosses over into level 2 anyway, just things you would generally ask your patient, you know, especially if they're up at night, peeing and things like that. So if they're on any type of loop diuretic or any diuretic, you know, are you taking that at night or too late in the day? And could that be the reason why you're having to get up and pee so often through the night? So I think you guys can figure that out. You're pretty savvy on that.
And also to study for the HESI, I know it's going to be, because you guys like had no clue on what's in that, right?
So HESI is based off of the level 2 concepts. So again, so I would look at, and this is what I told the 3rd level students for their Q&A session yesterday. I would look at all the exams you've taken. So the exams 1 through 4, and the exam you scored the lowest on, that's basically the one you're the weakest in. So that's the information I would study first. Okay, so I'd study that information first, and then I would go from my next weakest, but you know, I go from my weakest to my next less weakest, and then to, as you move to your strong. Your strong should just basically be review. So the stuff you knew solid, that should be review. So you shouldn't be spending a whole lot of time studying stuff you already know. If you're going to maximize your time and get the best utilization of your time, then I would start with the material that I was the weakest at and then build from there. So that's the gap to close, because the stuff that you were solid in, you're not going to become unsolid in it. Does that make sense? But you're still going to review the material, right?
Right.
So that's what I'm saying. Don't spend time on stuff that you knew really well. Spend time on things that you struggled with, and then close that gap. And then when you take the comprehensive, it'll also give you an idea of where your weaknesses were again. And then I would start with the weaknesses of where you were, and then go back to, and then review the things that were your strongest points.
Gotcha.
So, you know, hopefully as you guys progress through, and I think your test is Tuesday, right?
Yes.
Yeah. So then you have time. So I would study in chunks. I would not try to study all of the concepts every day. I would study a little bit here, a little bit there, a little bit here, a little bit there. And remember, you're trying to get this into long-term memory, but usable information. And, you know information, but let's try to apply information. So, if you were going to get, say, for instance, you had a patient that just came back from surgery, okay? And the patient has invasive lines. And an invasive line could be like an peripheral IV, it could be, and then it could be a Foley, it could be a chest tube. Either way, you still got to get the patient up, right? It could be a Jackson Pratt drain. So what things would you do? What actions would you do to help facilitate that individual, ambulating? So what are some things we should do once we know folks have had, any surgery? And even if it's just for them to, get out of the bed and sit in a chair, what will we do?
Possibly make sure they have their pain medication.
Okay, I like that. What else?
Make sure they're
Vitals.
breathing.
Okay, so vital signs. What was it? Someone said something, but I couldn't hear it.
Make sure they do the deep breathing exercise, coughing.
All right, so
Position.
pulmonary toilet. Okay. What else? So if this is their first time, ambulating after surgery.
Education on how to do it.
Okay, so you're gonna let them know this what our plan is. How we gonna elevate you. What do we want to know? Anything else? What are we gonna do? Please let me know how this makes you feel. What else?
Safety, make sure that they're not dizzy, monitor for hypotension.
So check vitals. So check a blood pressure. Absolutely. Ask the client to let you know if he or she is gonna feel, do you feel dizzy? Or even if you give somebody, you could take that same process just with somebody elevating. And if they are going to receive a blood pressure medication, the first thing you want to do is check a blood pressure before you give them the blood pressure medication, because they may not need it. It doesn't mean they will never need it. It just means the blood pressure may be too low to support receiving it. That's one. But also you want to ask them to tell you about dizziness, or you want to tell them about dizziness or elevating too quickly. So, you have the teaching behind it, then you have the actions and nursing responsibilities behind administering that blood pressure medication. Does that make sense? So, if you have people from, that recently come out of surgery, that things we're concerned about is airway, breathing, circulation, any shortness of breath or anything like that, that's going to be, extreme, excruciating pain. I mean, maybe there's something that's definitely wrong. It could be, something left in the body, but those are things that we would be monitoring for. Does that make sense?
Yes.
Yes.
Okay. So, just what are your nursing actions? What nursing actions would you do for, a situation? What are some common signs and symptoms that are seen in a particular condition? So, like the last test we talked about diverticulitis. So how do you know what would be the patient's complaints if they had diverticulitis? What would they complain of?
Left lower quadrant pain.
Yeah, left lower quadrant pain. And since it's an inflammation they may potentially have a what?
Infection. Fever.
Fever, exactly. So the person's, this is another thing that I tell third level students. Your patients are not going to walk in and say, I have an infection. They don't know exactly why they're having the low grade fever, but evidently the body's trying to fight something. You know what I'm saying? So what would the patient present? what would they say to you? What would be the vital signs that you would see with that particular individual? Those are the things that, you want to look at. If someone was a type 1, diabetic, and they were having insulin shock. What is insulin shock? that was one of the very first concepts we talked about. When we talked about type 1 versus type 2 diabetics. So if you have that type 1 diabetic, they're insulin dependent. And if they have insulin shock, then they have too much insulin on board and not enough glucose. So they would present like for hypoglycemia as if they were having signs and symptoms of shock. So what are signs and symptoms of shock? So, you know, when you see, you know, something like that, you know, those are teaching mechanisms or teaching things or teaching tools you want to tell your patient that if you don't eat, then you can go into insulin shock because you'll now have too much insulin on board and not enough glucose, so that you'll be out of balance. But if it's, you know, you have hypoglycemia, how would that patient present? What would they look like?
Cool, clammy, and diaphoretic.
So cool, clammy, diaphoretic, they'll be tachycardic. They're going to present like they're in shock. They'll be trembling. So, you know, those are the things that you would be seeing. You know, if I was to see this patient, if it was my patient and you were on the floor and they were there for something else, but you knew they were a type 1 diabetic, then that, you know, how would I know what you know, what would help me understand, you know, what I'm looking at, you know. So we've been talking about these things all the way throughout. I mean, we could take that same, you know, type 1 diabetic and just, you know, say for instance, maybe this was a type 2 diabetic, and for some reason now, you know, the person is whether they were compliant or not compliant, it doesn't really matter, but now they have to get insulin. Okay, what will be some things what will be your teaching about this process? Or if somebody was just newly diagnosed with diabetes and they have to get insulin, what will be your teaching? What will be your teaching plan? So some of you have done these teaching plans already when you were in OB. So what teaching plan would you know, what would you tell the patient? What are some things you need to include in that plan? What would you do before you do the teaching? What are some things you need to consider?
Blood sugar, rotate sites.
Okay. So, you know, we want to tell them about normal levels. Okay. We want to tell them about sites. You know, they need to learn the different sites for which an injection can occur. I'm so sorry. What else? I mean, before you do any teaching of any client, even if you was teaching a person how to crutch walk,
do you want to like evaluate, like, I guess, how much they are actually going to learn, like their education level, I guess?
Absolutely. What's the patient's developmental level? You know, can they read? Can they understand what you're saying? You know, do they really want to learn? Some people have to go through the grieving process, literally, as they process, I have diabetes, and now I got to do finger stick blood sugars, and I got to do insulin. Do you see what I'm saying? That's a lot to process. And then they may know people that had to do insulin injections and, you know, that may have diabetes and their outcome wasn't really great. So you have to see if the client is even willing to learn, and then, you know, what their developmental level is. So anytime you're doing any teaching, you for sure want to check and see, you know, do they know anything about the condition, any information that would help facilitate the learning, because that'll let you know how basic you would need to be with the information, because you want to start basic. You don't want to be too in depth, and then you want to do that teaching over time and then recheck it later in the day. Does that make sense? So if I go in at 9 o'clock, all right, we're going to talk a little bit about, you know, so, you know, tell me, I'm going to tell you some things about diabetes, and then let me assess, you know, what you actually understand. But you can look and see if they have a college education or whatever, because that's part of their demographics when they check in. So you kind of understand, hey, if you need to ABC this, or can you do an A squared plus B squared scenario? So, but don't go medical terms. You still have to do layman's terms, but at least you can feel free. You at least know your movement in that. So do those things make sense?
Yes.
Yes.
Okay. You know, if you do have somebody that has, you know, DKA, the first thing, how do we treat that? How do we treat that as nurses?
Maybe get like a basic glucose level.
Okay, well, for sure, you're gonna, if you know, if they're in the midst of the DKA, you know, understand that you're going to be checking finger stick blood sugar. So that'll be, you know, that will, on the other side, that person may have to go home and do that. So now you got to talk about that machinery as well. But if they're on your floor, then, you know, how do we help eliminate the ketones?
You want to hydrate them, correct?
We do. We want to give them some normal saline to start that flushing process. So we want to make sure that, you know, we got a patent IV. And here's the thing, you guys not doing clinicals this semester, next semester it's going to be pretty scary, because, you know, you're going to be like, well, we didn't do this last semester. You're going to have to rise to the occasion, and don't be scared of what you already know. Some of you are in a medical facility already, but remember, you can't bring what you do at your facility to somebody else's facility. Does that make sense? So just kind of be mindful of that process, that you don't start crossing over your protocols into somebody else's place. But, you know, things to consider though is, or things to consider are, first, I'm going to be checking these finger stick blood sugars. The person may be on an insulin drip. I do need to hydrate them, so they're going to be on a saline drip. I need to make sure this IV is patent. You know, sometimes the ER, they have a muckety muck. It may not even be a muckety muck. It may be that you put they may have put the IV in the patient's antecubital fossa. They didn't splint the arm so that the patient keeps it straight. So they're bending their arm, and the catheter inside is bending, which means it's not going to hold up for too long. And if that is like the place where everything is being done, like they're giving all their medications through that, their fluids, then that IV is going to tire out really quick. So don't be, get really proficient at IV starts. Work on it. Go to the lab when we open up and practice those IV starts. That way, you won't be afraid of putting in a 20 or 18 gauge. Because sometimes that 22 just doesn't work. So just think smarter for yourself. Like, you can't give pain meds and then draw blood from it and all this other kind of business. That thing's going to tire out real fast, especially if it's a 22. What if this was a pregnant person? How do we manage our gestational diabetics, or just people that, may have already had diabetes and now they're looking at, a pregnancy, or they're pregnant? How do we manage them with their insulin? Do we do anything different?
Yes.
Okay, in what way?
I don't know. I was hoping to everybody answer that part of the question.
Okay. Anybody else want to take the second half? So will we do the same thing for every patient?
No.
No. So this is going to be patient dependent. However, you will probably have some adjustments in the insulin. It depends on how well the patient manages their food intake, so their carbohydrate metabolism, if they do low glycemic versus high glycemic. So all of those things are things that you will probably need to consider. But overall, expect to make some adjustments in that based on what the blood sugar level is. It may be this number versus that number. So it's no different than if they were a non-pregnant person. You're still going to make adjustments as needed. So it's not a one size fit all. We have some parameters, but it's still going to be sliding scale, and that sliding scale going to be all of it's individualized. But just understand you're going to be doing some management thereof. So does that make sense? So try not to put everybody in the same boat that we do the same thing for everybody. The physician's going to basically make that call and then tell you when to call him or her. So, be mindful of that. What are some complications of diabetes?
PVD.
Peripheral vascular, okay.
They can have type 2 diabetes after birth, preterm labor.
So you're talking about gestational diabetics. So if you were a person that was not a diabetic prior to pregnancy, then yes, you have a 50-50 chance of becoming a type 2 diabetic sometime later on in your life. But just what are some complications of diabetes as a whole, whether you're pregnant or not?
Retinopathy, coronary artery disease.
Okay, retinopathy, coronary artery disease. What else?
Kidney failure.
Kidney failure, okay. What else? And why do they develop things like the retinopathy, heart failure, heart disease? Why does that happen?
For the most part, it's relative to the vascular disease issues, buildup of the atherosclerosis.
Okay, so if you have to treat a diabetic, why are you treating it? If you had to treat a person with coronary artery disease, why are you treating them?
Because they're symptomatic.
Well, why are they symptomatic?
Poor compliance.
Poor compliance. So they have poor, glucose control. This is why they develop things like retinopathy. If you have poor control over your lipid levels and things like that, then yeah, you're going to have problems. You're going to start seeing some other signs and symptoms that are going to develop that are not going to be favorable, So, your teaching plan for all of that would be, which we talked about, especially people that are newly diagnosed, developmental level, willingness to learn, how to do the glucose test, how to manage diet and exercise, sites to rotate, how to give it, how to draw it up, clear before cloudy, what syringes to use, how to read it. Do you see what I mean? So it doesn't matter if it's a child, whether it's a pregnant person, whether it's an adult. Have we named anything different as far as management?
No.
No, the management is the same. The teaching is the same. And depending on the age of the kiddo, that may be a determining factor. But now we have insulin pumps, We have Levemir. So we have different delivery systems, but we still have to teach it. You know, what do you do? What do you not do? You know, what works? What doesn't work? So what does insulin do? And where do we not need insulin? So what does insulin do in the body?
Moves glucose and potassium into the from the extracellular spaces into the intracellular spaces.
So basically, it's facilitating glucose transport into the cells. Which organ does not need insulin to transport glucose into the cells?
Is it the brain?
It is the brain. That is the only place where we do not need insulin for transportation. So the brain does not need it. It accepts glucose on its own. So we don't need to worry about that piece. Okay. All right. So any other things about, you know, diabetes? So that's that metabolism. So I just figured we should just start there and roll on through, because I wasn't sure if we were going to even get a starting point. So this got a little wonky. So what if let's get part of nutrition. So let's talk about that. So what if you had an individual that was, you placed in a nasal gastric tube, and, you know, all of a sudden your patient starts to vomit? What should you do?
Raise the head of the bed.
Okay, I like that. So basically, definitely do not leave these patients supine. Okay.
Discontinue the pump.
I mean, we don't know if it's connected to suction or not, but I like to raise the bed. What else can we do? So where is the nasal gastric tube? Where does it end up?
In the stomach.
Okay, so if it's in the stomach, then it should help like decompressing the stomach and stuff like that, right? So,
So we should check placement?
Placement, you should check patency, see if it's actually, you know, operational. So those would be things that, you know, we should check to make sure. But we're not going to have them supine, you know, but we want to make sure our equipment's operable before we start looking at giving medications and things like that. But you want to notify the physician to see if that's not already in your orders, your admit orders, or the patient's chart, you know. And I would actually tell you know, the physician, or call the physician, hey, you know, FYI, anything, you know, you have any additional orders you want to provide to facilitate that. Okay. So don't forget about your numbers. So your LDLs and all of that, you're still responsible for it. Your BNPs, your triglyceride levels, your HDL levels, all those things that relate to coronary artery disease. Your beta, your hemoglobin A1C, beta, your hemoglobin A1C. So all of those numbers you still need to identify or have them committed to memory, and you need to have it committed to memory anyway, because you're going to be hopefully utilizing those numbers or utilizing that information in clinical. So hopefully, you know, in this fall we'll be able to do clinicals face to face versus online. All right. I think our next, I'm trying to go in order. We did metabolism or nutrition. All right, so if a kiddo has a thyroid problem, how would that impact them overall? How would you know? How would the patient present if they had a thyroid issue?
Be fatigued.
Okay. But this is their first diagnosis. So they're like new, they're about to be diagnosed. They hadn't been able to figure this out. And so if this is a kiddo, how would that affect them? What does the thyroid gland do? What is it a part of?
It's metabolism.
Okay, metabolism. So metabolism plays a role in what?
Growth.
Growth. So that kiddo may not develop appropriately. So they may have delayed growth, delayed cognition. So those would be some things to investigate, because that would be an expectation. Does that make sense?
Yes.
Yeah, that's why you guys sound like you're so like, you're almost done. You're almost there. So just, hang tight. So know your signs and symptoms for hypo and hyperthyroidism. So don't forget about those. I think we can leave nutrition and metabolism. I'm trying to see what else was trying to see if we had ulcers in there somewhere. I remember. So what about and I'm not sure if that's I think this was also in there, like your bulimics and your anorexic folks. So bulimics, what do they do? How do they their condition present?
Bad teeth, vomiting.
Okay. So they basically eat a bunch of stuff and then puke it up. And so, yes, they will have bad teeth. They definitely will be, emaciated, maybe, depending on how bad it is. So if they're puking, what are they also losing?
Electrolytes and fluid.
They're losing volume and they're also losing electrolytes. So, we want to make sure, we're monitoring for that. They may have signs of dehydration, tachycardia, but their potassium levels may be low. So, we need to check that information as well. They definitely would have, especially with your anorexics, because they're not eating. So there's a whole nother difference. At least bulimics put some food in, they just puke it out. Anorexics, they're like, I can't eat. See this one small little pocket of fat. This is like, 100 pounds of fat. It really isn't. But they have, their body weight and height is definitely below where they should be because of all of the believability that they are actually overweight and fat and all this other kind of stuff. So it's pretty crazy on how they think about things. So yeah, just, kind of remember those types of situations. What would you see in a bulimic person? What would be your concerns? How would we treat this? Okay. So what if you have, okay, so we talked about nasal gastric tubes from the standpoint that you need to check placement. What's our gold standard for placement?
X-ray.
Okay, it's an X-ray, so we got to get a chest X-ray. Okay, so if you place one of those in, and then your patient starts developing abnormal breath sounds like rails, and you haven't gotten the chest X-ray results back yet, what would you do?
Discontinue it immediately.
So pull it out?
Yeah.
Okay, absolutely. What's going on now?
Use the tube.
May not necessarily you mean when you say miss the
You went in
esophagus?
the wrong. Yeah, you went in the wrong hole.
Okay, wrong. So it's probably in the trachea. Okay. And there's a potential that, we put something down in the lungs that did not belong. So that should not happen after you place the nasal gastric tube. All right, so high blood pressure. I think we just recently talked about that. Let me go in order. What was next? After we did nutrition, we did metabolism. What was the third one? There was three.
Clotting.
I think it was
Yeah, I
clotting.
think it was clotting.
All right, so, clotting. If you give somebody a coagulation modifying medication, what are some things you need to teach them?
Using other medications like aspirin, signs and symptoms of bleeding.
Right, so if they're on Coumadin, if they're on warfarin, if they're on Plavix, if they're on aspirin, those are all coagulation modifying medications. So we want to look for bleeding gums. We want to look for blood in the urine, blood in the stool. Those things would be abnormal, coughing up blood. So just making sure we understand our teachings related to that, because those things would not be normal. Okay. Does that make sense? So making sure that we're very conscious or conscientious about, if you're taking these coagulation modifying drugs, and this is the reason why I just didn't call out aspirin, because aspirin is an antiplatelet. And what does that mean?
It stops platelet formation.
It doesn't stop platelet formation. You still make platelets, but they make the platelets slippery.
Less sticky.
So yes, they make the platelets less sticky, so they become slippery and they don't clump together and create clots. So that's really the action of platelets. But we want to make sure they understand about, the bleeding and what that entails, so that way you have, they know what to look for. And they could still have bleeding, but we just won't see it. What is that called?
Occult.
Occult blood. That is true. Okay. So we didn't talk about DASH diets. So, or people who would be instructed to actually take it or start on a DASH diet. What population would that be? Or not population, but what condition would we use DASH diets for?
Heart disease.
Hypertension?
High blood pressure. So yeah, high blood pressure, we have signs and symptoms of, it could be a headache, they could have a epistaxis, and that may be your only sign that the person may have, high blood pressure. So that would be pressure greater than 140/90. Pre-hypertension is between 120 to 139, 70 to 80, 80 to 89, 80 to 89. That'd be your pre-hypertension. So we want to talk about salt intake, minimizing that. So, like the bacon and deli meats, canned goods, those would be the things that we would stay away from. What culture is more popular to have or common where high blood pressure is prevalent?
Us, African Americans.
Yeah, that's true. Black people, African Americans, and both men and women. So it's not, it's kind of equal across that board, which is kind of, bizarre. So, what else can we talk to them about? Because there's other things that high blood pressure can lead to, especially if it's not treated.
It can lead to blindness, right? It can mess with your eyesight, heart disease.
Heart failure, more specifically, but yes. So the patient can have a stroke, right? You remember?
Yeah, heart failure, retinopathy, nephropathy, strokes,
Yep, kidney failure.
coronary artery disease.
So you have some big ones there. So, don't get distracted by that, okay? So we want to be monitoring that sodium level because, if aldosterone, it releases sodium, right? And then it also causes water retention because water follows salt. Exactly. And I believe it also plays a role in potassium, if I remember correctly. Okay. So is there anything else in that first, that would be all of exam one's stuff? All right, exam 2 kicked off with gas exchange, which was your COPD, asthma. I think aspiration pneumonia fell underneath there. Then we did immunity with like cellulitis and trauma, and was that transesophageal fistula and vaccinations, kidney, renal. There was some kidney stuff in there as well. So let's kind of talk about that. So with your COPD folks, what are some teachings you want to do for them? What are some things they should do on a consistent basis?
Pursed lip breathing.
Well, that'll be for emphysema.
Spirometry?
Well, will they have that at home?
So, if they smoke, they need to quit smoking.
Okay, I like that.
Would it be rest, like take frequent rest breaks?
I mean, if they're having a flare-up, yes. But what do we tell them that they need to receive every year?
A pulmonary function test.
No, a flu shot. They need to, because they're immunocompromised, so they need to get a flu shot. And then they need to make sure that they're taking their pneumonia vaccine, making sure they get those at the appropriate time. So, when you have those people, you need to make sure that we're telling them that if they develop a fever, that this is not their disease condition. This is now actually their what? What is it?
An infection.
It's an infectious process, okay? So those types of things will be things you want to talk to them about, so that way they know what to look for. How do I know that this is not my, this is not my disease condition, or if this is something, more than my disease condition, and I need to seek care. So understanding those components, and what medications do we use to treat that?
Bronchodilators.
Bronchodilators. So, understand what your acute phase is, and then things that you would use or patients may use on a long-term basis. So that was that article that you also had that assignment in P&C about for COPD. But what is the rationale for them getting these, the pneumonia vaccine and getting the flu shot? We don't want them to develop these infections, because do these infections help their condition get better, or does it make their condition worse?
Worse.
It makes it worse. So, they are going to be more susceptible to developing infections. So, we want to make sure we minimize that. And if they get an infection, how does that impact the body? Will they have more or less oxygen available?
Less.
They'll have less oxygen available, and these, this can be really significant to the point that they end up not surviving. So it's important that we do pay attention on, and we're vigilant in letting them know why it is important for them to receive these vaccines. Because, nobody really wants to get needled up all the time, but we do need to make sure they understand, the importance of it. Looking at vaccines, since we're talking about vaccines, remember to know all those vaccines within a year, what kiddos need to have, what are the schedules? 2 months, 4 months, 6 months, what do they get at a year, those first year vaccines. So know the categories of where they are. If they're at 2 months, what shots do they receive? 4 months, what shots do they receive? So that way you understand about that, because those are the only ones that you were responsible for. Other things that was a part of that was osteomyelitis. That was on the immunity side. And with osteomyelitis, will they go home on PO meds?
No.
No. So they need to have some type of PICC line or central line of some sort, because they're going to go home on IV antibiotics, and they could be on that for up to 6 weeks. But, other things, how will we treat osteomyelitis, which is an inflammation of the bone marrow? So besides antibiotics, what else would we potentially do? To help the bone heal.
Would you do steroids?
You do what?
Steroids or no?
Is that a part of it? Because this is a bone infection. So is that making the bone healthy?
Maybe vitamin D?
Surgery.
I don't know if we do vitamin D. At some point we will, to help with calcium. But first, before we can get that, we also need to get rid of what first?
Necrotic.
We need to get rid of the infection. So they may actually have to go in and scrape all that stuff out. So they may get surgery to, get rid of all of the necrotic bone in there to see, see what's left. Depends on how bad it is. So, we need to be checking CBC levels, all of that. White cell count. But they may have to get that leg, get a debridement done on it. That's the word for scraping it out. Signs and symptoms of a kidney stone. Signs and symptoms of a UTI.
Blank pain.
So let's start with, let's start basic. Let's go with just regular UTI.
Painful urination.
So dysuria, so painful urination, okay. Hematuria,
Frequency.
say what?
Frequency.
Frequency, urgency, so the urge to void, then they get there, have the bladder spasm, only a trickle comes out, lower abdominal pain, what else?
Fever.
Fever can be part of it, the patient can have chills, and you know, that urinary tract infection could be in the bladder, the ureters, or go all the way up to the kidneys, right?
Yes.
Okay. So if they have a kidney stone, that's going to be hella painful for the individual. So, you know, before we talk about the kidney stone, let's talk about how do we treat a bladder infection? What do we tell them to do? They may get antibiotics. Okay.
Also liquids.
Vitamin C.
They could do vitamin C to help change the environment in the bladder so that the bacteria doesn't stick to the bladder wall. True. How much fluid should they drink per day?
A lot.
Yeah, about 2 or 3 liters. What else can we tell them to do?
Wipe front to back.
Cotton underwear.
Cotton underwear, front to back, no tight clothing. Take your medications as prescribed. Any other medications they're given. How about cranberry juice? Would that be good?
Yes.
Cranberry juice would be fantabulous.
And eat asparagus.
Say that again, please.
Sorry, I said and eat asparagus. That's what you told us last time.
Yeah, asparagus definitely does help with your kidneys. But the other thing you could do is making sure, they pee, don't try to hold it, but just, kind of make sure they urinate. What about soaking should they do any sitz baths or anything like that?
No.
No soaking in the bubble baths. No bubble baths anyway. I mean, half of those chemicals in there are definitely not good for you. So, just understanding things that you would need to do for cystitis. Okay, trying to see what else. You did hear that, because I'm thinking through. I think that was all of the immunity stuff. And anytime they do get a reaction, anytime they do get a vaccination, they may have some mild reactions, especially kiddos. I used to pre-medicate my kiddos before they actually received their vaccinations with some Tylenol just to prevent them from developing a fever. I'd actually go in there in their diaper bag with little ice cubes, all of that. So I know that doctor thought I was crazy, but I didn't care. She got over it. But she understood too. She was like, you come prepared. I'm like, I surely do. I'm gonna have time for that. I think I did the double bump on my daughter. She got vaccinations and then I got her ears pierced at the same time. I said, oh, she's already pre-medicated, so I might as well finish the rest of it. Okay. So I think that kind of covers everything we did there would, oh, how do you, if you have an injury, because I think hemophilia was part of that one, the immunity. If you have an injury, how do you treat that patient that has hemophilia? What do you tell them to do?
Acronym RICE.
Okay, so absolutely, you know, rest, ice, elevation, and what else? Anything else? Compression. What's the compression?
ACE bandage.
Yeah, it would be the ACE bandage. So since we're talking about immunity, let's talk about pneumonia. How do your elderly patients present for pneumonia and for urinary tract infection?
Confusion and no fever.
So they'll be confused, but elderly usually do not have a fever. They may have tachycardia, but they don't have a fever though. And that's usually the difference between, your children and your adults, and not your older adults, but your younger adults. They're not confused, number one, but they may have coughing and fever, whereas an elderly will be confused and have no fever, but may have tachycardia. So who would be more at risk? What types of patients are more at risk of developing pneumonia, from a community standpoint?
Like elderly.
Like nursing home?
No, that will be hospital based. So this would be like in your neighborhood. What patients would be a vulnerable population to develop or to catch a community acquired pneumonia?
I guess like low income that don't have access to healthcare.
Yep, low income. So anybody who doesn't have access to healthcare, number one. So that could be, below or at or below poverty line, homeless, immunocompromised. And then if they smoke, would that help?
No.
No. So those types of patients, would not be, that would definitely be an issue, because smoking changes the cilia, right? So if you're a smoker, the cilia, the things that help to give you, move things out of your lungs, it wouldn't be available. If you have any ulcers or GERD, should you smoke?
No.
No, that's going to irritate. Should we do big, large meals or small meals?
More frequent meals.
Small, frequent meals. Okay. Asthma. Tell me some signs and symptoms of asthma, which would be very similar, have the same similar signs and symptoms for COPD. What are those?
Dyspnea, diaphoresis, tachycardia.
So dyspnea, what else you say?
Tachycardia,
Wheezing.
Who would have wheezing?
Asthma.
Okay, so yeah, have that.
Retractions.
Bronchial tract is inflamed, where you have mucus production. If it's COPD, they're going to have copious amounts of mucus production. You don't have the same with emphysema. That's pretty much a non-productive cough, but they do have a difference in appearance because your chronic bronchitis is more obese, right? Your pulmonary, your emphysema, they're usually more skinny. They burn a lot of calories. They have that barrel chest. And then they may have retractions, right? All those retractions, substernal, suprasternal, sub and supraclavicular, intercostal retractions. And that's usually, is that on inspiration or expiration?
Expiration.
actually inspiration. Same thing for kiddos. So, you know, they have those intercostal retractions on inspiration. So, you know, whether we're talking asthma adult, asthma kiddo, or COPD, now kiddos usually don't have that unless they're missing they have that antitrypsin, you know, deficiency, alpha antitrypsin deficiency. But primarily, you know, when you're looking at retractions, they would be tripod position. They would have increased work of breathing, which would be the nasal flaring. And I'm talking about kiddos right now. Nasal flaring, the head bobbing, the grunting, the retractions. So you would be looking for those things. Now, adults can have retractions too. They can have that air hunger. They're just trying to find a corner of air to catch a breath from, right? So you kind of go back and, you know, review that material. You guys know this stuff, but for some reason right now, you're just like, I don't know. So, yeah. Trying to see if that was everything. So we give them the beta 2, we give them steroids, right? So my question for you is, as you're treating these folks, what would you anticipate? So if you're treating somebody that has asthma, and so you said that they would have wheezing, right? When you give them a beta 2 agonist, would they have less wheezing? Would you hear less wheezing upon auscultation or more wheezing?
You could hear more sometimes.
You would actually hear more wheezing. So after they receive their treatment. So if you're giving them a breathing treatment, and remember, we can give them albuterol, we can give them Atrovent, they could get, which is the A and A, which is a duonev. There's a lot of different, they get Zopanex. So you would expect to hear the wheezing more prominently or more clearly. They would be more vibrant, but you would hear more of it. If you have a low potassium level, what are you at risk for? Remember, too high, too low K, what does that, what's the problem there?
Arrhythmias?
Cardiac arrhythmias, absolutely. So the heart doesn't like potassium to be too low or too high. So that is something you definitely want to pay attention to. You know, don't forget, go back and review your electrolyte imbalances. You know, when does a person have SIADH versus DI? You know, what would you be looking for? What would be the signs and symptoms? Because I know if I ask you that now, you'd be like, oh, I'm not really sure. Your page is turning.
I have a lot of pages. Hold on.
Yeah, remember, would their sodium levels be elevated in SIADH?
DI is elevated sodium, and SIADH is dilutional hyponatremia.
So they'd have a dilutional hyponatremia. So that would mean their sodium levels, if it's delusional with a T, then that would be a low sodium.
Yes.
Okay. But because of the excess fluid, they would probably gain some weight. or have an increase in their weight because of the excess fluid, although it's internal. Does that make sense?
It does.
Okay. All right. Can you stop taking your glucocorticoids? So like prednisone, can you just stop that abruptly?
No.
No.
You got to do that over at least a week to, a week to 2 weeks. If you stop taking your high blood pressure medication, what's going to happen?
You're going to spike up.
Your blood pressure is going to go up. That was the whole purpose of you taking it in the first place, was to keep the blood pressure down. So make sure you educate your patients on that. Don't stop these things abruptly. That would definitely not work in their favor. So the odds will not be in their favor. So back to electrolyte imbalances, since we're here. So when we talked about hypokalemia, what were some causes of hypokalemia?
Loop diuretics that are not potassium sparing.
Okay. What else?
Vomiting.
Okay.
Placement of it in G
Water
tube.
intake.
Okay. What about medications?
Yes.
Which one?
Laxatives, diuretics,
Okay. What other one?
corticosteroids.
Keep going.
That's all I got.
Too funny. Okay. Which one could lead to toxicity?
Johnson.
Digoxin. So yes. So if a person is on digoxin and their potassium level is low, are we going to give them the digoxin?
No.
No.
It's going to be a negative.
It's going to be a negative. I love it. So, think about those things. So as you're reading the questions, pause for a minute and say, what are the questions asking me? What are my toxicities? What things do I need to, pay attention to? You need to pay attention to all of it, but even if they have a thyroid hormone toxicity, how would they present? So remember, thyroid is metabolism. So if we have too much of it being produced, that means our metabolism is going to be elevated, right? So everything.
Yes.
So we'd have a fast heart rate. The patient may have some chest pain. Everything's going to be up. Whereas, the other side of that, hypothyroidism, they're going to be, cold intolerant. Things are going to be slower. So their heart rate may be slower. So, know your opposites. And even when you're looking at your kalemias and natremias and your mags, those are the same things that, we've kind of talked about already. And the last two are kind of more recent. So I don't know if there's too much we need to review on that, because those are the recent things that we had. Acid-base imbalance. So what's a metabolic alkalosis, metabolic acidosis? So you need to go back and review those things. Respiratory acidosis, respiratory alkalosis, that's all part of gas exchange before we got to fluid and electrolytes. And then, if it's a pregnant person and they're in labor, then, how do we, treat them when they're, complaining of dizziness and so forth and so on. So it's something we normally don't do, but for this patient, we will do.
At the cupped hands thing?
Or the paper bag, yeah. The other part of immunity was sickle cell. I was like, I know there's one more that I'm missing. So, how do we treat that?
Was it hydroxyurea was the prophylaxis for it?
Okay. But, you know, if they're having a crisis,
Pain meds,
we're going to give them pain
fluids.
Absolutely. Fluids, absolutely. So speaking about pain, you know, kidney stone, hematuria, urinary frequency, you know, lower abdominal pain. And where is that going to radiate to?
The flanks.
Well, it'll start flank. So you'll have lower abdominal pain, flank pain, and what other pain? There's one more.
Is it suprapubic pain?
Groin. It'll go down to the groin. Because they're going to be in that fetal position. And then we need to look at their diet because there's all types of kidney stones. But, you know, usually calcium oxalate or oxalates and they have struvites. There's different stones, but calcium is one of the bigger ones. A lot of that's from drinking a bunch of soda and not drinking enough water. RSV was a part of that. So, you know, knowing about your isolations, how do we treat it? So if we have someone that has a kiddo that has RSV, you know, bronchodilators, give them fluids. Think about, you know, clustering care. What would be another condition that we should consider clustering care on?
Heart failure.
Okay, heart failure, but I'm speaking more kiddos. There was a couple of exemplars that we talked about care clustering. And RSV was one. It was in the beginning with the nutrition.
The premature babies.
It's like the ones with drug dependencies.
Oh, the failure to thrive.
Failure to thrive babies. We definitely want to look at clustering the care, having routine, the same people. What else?
Be good patient teaching with the family because the poor development possible to social and psychosocial.
Remember there was a question to add about that, or it wasn't a question, but what else can we consider as a part of their care? Because if they're failing to thrive, then that means they may not eat, but they also need some things.
So TPN?
One TPN. Oh, you guys gonna be like, really?
Vitamins?
Polyvisol, they need vitamins. Yes, absolutely. And I remember that being a big, it was like, oh, I forgot about the vitamins. I didn't know babies can get vitamins. I was like, yes, it's called polyvisol. Multiple vitamin is what that is. Let's see what else. There's a couple things on about failure to thrive. Which vaccine should you not give, especially if there's somebody at home that's immunocompromised?
The live vaccines.
Live vaccines.
Live vaccines like your mumps, measles, and rubella. So, yeah.
Can I get clarification on the live vaccines? I have MMR, varicella, and rotavirus. Is rotavirus the live vaccine?
I believe so.
Okay.
Yeah, I believe so. Varicella definitely is. and they don't give this one anymore, but that smallpox vaccine, and you would know if you have it because it actually leaves a scar that you carry with you. But at one point when they were concerned about all of the anthrax, they started re-administering the smallpox vaccine, and people started dying, and they were dying because they had underlying cardiovascular disease, so it actually increased their problem. So yeah.
It's also very painful.
Yeah. So, you know, just don't forget about your bites or your immunizations and what people can and cannot receive. So if you have a baby that has croup, how do you treat that? That's the one with the seal barky cough.
The steam showers.
Yep, that'll be good. What else?
Steroid, like dexamethasone.
Okay, usually cold mist works better, or the steamy shower. It depends on how bad it is. We'll look at how deep they go. But the thing that works best for them is having that humidified air, because they're looking at where the swelling is. Is that bacterial or viral?
Viral.
That's viral. Okay. So tell me about transesophageal fistula. So we talked about that. What is that?
It's when the trachea and the esophagus are fused, so they can't swallow anything. It goes straight to the trachea.
Okay, so they kind of have like a blind pouch, and then they have an opening. So there's different types, but regardless, there's two connections, and one doesn't go anywhere, and one opens up an area to go somewhere. Does that make sense? So when I showed you all those pictures of TEFs, and how do you know the baby has TEFs? What is the 3 C's? What were they?
Cyanosis, cough, and I forgot the other one.
Help her out. What were those 3 C's for the TEF?
Is it choking?
Oh, is it? Is it choking? What did we talk about?
Yes.
Okay. You don't sound too sure.
Yeah, I got coughing, choking, and cyanosis written down.
I was gonna say, would you bet your paycheck on it? So yeah, cluster care. So TEF, that would be the CCC. We talked about clustering care for RSV people, our failure to thrive people, being consistent. You know, once they go home, should they have any follow-up visits? And if so, with who? Would they have to come back to the hospital, or could we give this to somebody else?
Somebody else.
Like who?
GI maybe?
Not GI. We're just talking about, I'm talking about your failure to thrive.
Oh, your PCP?
Yeah, your failure, your FTT people. Who can we,
Their pediatrician.
do they need a pediatrician after that? Can we have someone else come out there and follow up on them?
Oh, like occupational therapy?
All right, so
Speech
failure to
therapy.
thrive either they, they're not getting the nutrients that they need, or they're not getting, tender loving care. So for those folks, if we have someone like a visiting nurse come out there, they can check on them. And if there's a problem, then they can call the pediatrician. But they don't need to come back to the hospital for that unless there's a problem, they have an issue. Okay. All right, so, if you have somebody that has heart failure, what is our goal for them?
To avoid exacerbations.
Okay. What else? Do they have increased workload or decreased workload? And that'd be heart workload.
It's increased, so we want to decrease it.
Yeah, I mean, they're working hard. Remember, if you have that person who has that not managing their blood pressure, or they just said, I know I have high blood pressure, but I'm just not going to see anybody about it, whatever, then that person may develop heart failure. And don't forget the differences. We have left and right heart failure, right? So right heart failure, they swell up everywhere. Left heart failure, they usually have rales and JVD as their common signs and symptoms. But with right, you have the enlarged liver, you have the ascites, you have sacral edema, dependent edema of the leg and the arms, and they also have an enlarged spleen. So there's a lot of fluid, including JVD. But your COPD people, especially, they can also develop right heart failure or cor pulmonale. So, that is, those are things that you need to, remember that we just recently talked about. But the goal is to basically decrease the workload as much as we can, and looking at ejection fractions, looking at BMPs, so that way we know what we're working with.
Ms. Hudson, you said left and right heart failure has JVD, correct?
Yes.
Okay, just want to make sure.
Yep. Because it's still buildup, but they just, left usually cause right, but you can have right heart failure without left heart failure. So
right.
There's situations there where they're totally independent of the other.
Thank you.
Mm-hmm. Okay. So what else? Anything else?
I had a question about one of the ones we just covered, the neurogenic bladder.
Okay.
Could you just clarify with the self-catheterization? There was a question that was asking about like what it promotes or the benefits, and I knew it was independence and self-esteem. Does it prevent UTI?
Yes. So yeah, and when you have someone with a neurogenic bladder, okay, so if you just imagine a person with a neurogenic bladder means they cannot control if the urine expels out of the urethra. So that means you may actually pee on yourself, right? But if you are doing self-catheterization every 2 hours, so get on that pattern, basically like potty training. So your bladder training is what you're doing. So one or two things. So if you have a flaccid bladder, it can actually keep urine in there. Or even with a spastic bladder, it can actually retain urine. So you can end up with urinary retention because you may not evacuate all of it out. So just because you're peeing, it doesn't mean the whole bladder empties. So now you have retained urine, old urine sitting in there, and it can cause now bacteria to grow warm and moist. And so if you're doing the self-catheterization, you're training the bladder to actually to evacuate, and then evacuate as completely as possible, right? So you don't want to be that person to be, if you don't have, if you're not doing self-catheterization, then you may actually pee on yourself, even if you have on a Depends or whatever other, pad absorbent product. So that self-cath gives you that freedom to, feel close to normal, because you're working on some things, but you're not now having the embarrassment of, urinating on yourself. Does that make sense?
Yes, thank you. I was overthinking it and kept going back and forth with the UTI choice, just because I knew it's associated with increased infection, but I guess that's just like the Foley cast staying in.
I don't know if this guy had it or not, but before shelter in, I can't even remember where I was traveling from, but I was flying back to DFW, and it was an older guy that I was sitting next to. So this is an older gentleman. I won't say he had neurogenic bladder, but he definitely had a bladder problem. And he was nervous the whole flight. He was picking his face, picking pimples. And I was like, okay, this is just so gross. And I was like, okay, I don't know what the guy's issue is. But then right as we got ready to descend, they tell you. So we're like, we just crossed the Red River, whatever. And we're going to start our descent. We're about 20, 30 minutes before we land. So, the captain's going to turn on the seatbelt sign. Now, the guy could have gotten up and gone to the restroom, but he didn't. And when he got up, he had peed in the seat. And I was like, oh my gosh. And he had the biggest wet stain. I mean, you couldn't miss it. It was a lot of pee. So I don't know what the heck happened. But just imagine that happening to you. And I know he had to be embarrassed, but what was he going to do? Not walk off the plane? I mean, he had to get up and go out. So he just couldn't sit there. So, not having, not if he was able, he couldn't self-catheterize there, but I just didn't understand why he didn't go to the bathroom. I stayed confused on that. But I know I would have been embarrassed. If I wouldn't have been able to hold, couldn't hold the urine, or if I couldn't get up and go to the bathroom, or whatever the case may be. But just think about, that self-catheterization definitely helps with self-esteem, because you don't have to have those embarrassing moments overshadow other moments. So.
Thank you.
You're welcome. So anything else? Okay. You got about 25 minutes of my time. Go for it. What vaccinations can you receive if you're pregnant?
The flu.
Flu.
Okay.
Tdap.
Okay, so diphtheria, tetanus, what else? Any others?
Would the ROGAM be considered part of that?
No, we're talking about vaccinations.
Okay.
So like your, can you get varicella?
No.
Can you get mumps, measles, rubella?
No.
So
No live.
can they do a Hep B?
Yes.
Okay, so understanding when people can get vaccinations, when, where, why. I think you guys pretty much have it. What do you think?
I feel like I know it, and then I'm like, second guess myself.
Okay, so here, just take your time. Again, don't go with your first answer. 98% of the time, you've chosen the right answer, and then you start looking for zebras. And what I mean by that is you start talking yourself out the answer. So, only change it if you know for an assurity that this, you would bet your entire paycheck on it. If you're not willing to put your whole paycheck on it, then So most of you change right answers to wrong answers because you start overthinking. But the overthinking piece or second guessing piece comes when you haven't given your brain enough time to compartmentalize or put the information in long-term memory. So that's why I said, take the next several days and chunk this out. Make sure you get a good night's rest the night before. Make sure you eat breakfast and lunch, depending on whatever the time is that you're taking this test. There is no fire. You have 2.5 hours to do 100 questions. There's no fire. So, pace yourself. There's no reason to, get yourself twisted out.
Can I ask one more question, Ms. Hudson?
Yeah.
On the study guide we got, there was a question about wounds. I may say this wrong. Dehiscence?
So that I can barely hear what you're saying. There was something about wounds.
Sorry, I'm running from my kids. They're loud. It was a wound dehiscence, like when it separates, like after surgery.
Oh, dehiscence.
Yes.
Basically, putting too much pressure on a wound can basically cause it to bust open. So, making sure the patient is splinting that area. They're moving, not too quickly. They're not doing any extra stretching. So yeah, the wound can dehisce that, and you should have learned that when you went to the wound care seminar. Is that not correct?
Maybe I don't remember it. Sorry.
So, just understand that all wounds will not have a wound vac. So that's not, you may see that often, but every single wound, it won't have a wound. They may not have a wound vac. So it kind of goes back to getting that patient up out of bed. Like if they have belly surgery, then we want to get them up and, moving around. So they, especially if they're talking about feeling bloated and stuff like that, let's get that gas moving, get the GI system functioning. So it's things like, understanding that, but don't get hung up on the dehiscence of the wound.
Okay, thank you.
Because that's a small piece to the puzzle. So, if it's asking you something about a central line, you know, replacement and stuff like that, but understand what it is though. Understand that these, you know, just because they staple a belly back together or they suture a belly back together, or maybe they can't suture it back together and they leave it open and they just have like an open dressing on it, just understand things can happen. So just kind of be prepared for that. You know, what would it look like? Does that make sense?
Yes, ma'am.
Okay. Any other questions? All right. So again, just, you know, don't try to study concepts from nutrition to elimination every day. Don't do that. Do it in smaller chunks. Do it in 4-hour blocks. And then, you know, chunk it out. And then be done with it. You know, the older information, again, I would start with the information I knew the least. That's where I'd put my hardcore study time in, closing that gap, making it more, you know, making that foundation better. And then I would go to the stuff I knew solid. I wouldn't spend a whole lot of time on it. You know, don't forget about the coping and cognition stuff that Ms. Gordon sent you. So go back and review that information. The more recent stuff, I don't think I need to cover that because I think you guys have that. So, you know, I don't think I need to cover that in any length of any detailed length. Questions? If not, then I'm gonna let you guys at least rest for tonight and then hit it up on Friday, Saturday, Sunday, and Monday. But Monday, go to bed early. Get you some rest so that way your brain can put the information in the proper place versus it floating around in your mind and you don't really know, your brain don't know where to put it. And then you get to the test and you're like, I remember seeing something about that, but I can't remember what. Make sense?
Yes.
Yes.
Well, I'm gonna grab me some din and then I think I'm gonna pack it up for tonight.
Thank you, Ms. Hudson.
You guys are welcome. So while I'm eating, this should be downloading and I will definitely check on it to make sure that I can post it tonight. All right, guys?
Thank you, Ms. Hudson.
You're welcome. So if you need anything else, you know the digits or the email, either one. All right, guys, you'll do well. Just trust in yourself. You'll be fine. All right.